Welcome to Big Ideas in Overdose Prevention. Reach people where they're at. My name is Maridee Tucker, and I'll be running this Dialogue for Health web forum with my colleague, Jeff Bornstein. Thank you to our partner for today's event, the National Overdose Prevention Network, a program of the Center for Health Leadership and Impact. Let's meet the moderator of today's event, Dr. Carmen Rita Nevares. Dr. Nevares is the director of the National Overdose Prevention Network, the California Opioid Prevention Network, and the Center for Health Leadership and Practice, and also the director of Dialogue for Health. She is the Senior Vice President Emeritus of External Relations and Preventive Medicine for the Public Health Institute. Welcome, Carmen.
Yeah, thank you so much, Marlene, and welcome to everybody who's joined us so far. We are really, really happy that you can be a part of this discussion. I think it's going to be just really very thought-provoking. What we've done today, in case you haven't already been on the series, is we've got a few objectives we want to share with you. We're going to do a couple of poll questions, find out who you are, learn a little bit about you, and then we will show a bit of a video which is highlights from a series that we did last year, and then we'll launch into some questions with our co-presenter. So this is a really great opportunity for you to be engaged, and there are multiple places for you to engage. And let me just again reiterate, any comment you want to make, any questions you want to pose, put them in the Q&A. The chat is actually only enabled for the group that's putting together the background group, the production team. So anyway, let's go ahead and get on, and let's start with the learning objectives. Okay, so for today, what we're hoping is that by the end of this session, that you'll have thought of identifying an opportunity to reach a marginalized population within your community, so a new opportunity. We hope that you will gain skills on how to reach people in hard to reach areas of your community. And we hope that you will identify at least one strategy to make overdose prevention resources more accessible within your community. Next slide. So far in our Big Ideas webinar series, of which this is number 3, we've looked at why we need to invest in health equity and how to build partnerships that work in overdose prevention. Later on in the series, we will cover why we should be willing to pivot in our approach to overdose prevention, and why it's important to not reinvent the wheel when it comes to evidence-based practices. One thing I just want to note here is that if you weren't able to attend the Investing in Health Equity or Building Partnerships that Work series, please know that we make that available on our website, and you can view it, but just you wouldn't be able to participate in any of the discussion. So that's the value of being with us today live in person. Go ahead with the next slide. So let me now introduce our guest speaker for today. Dr. Maridee Shogren is a clinical professor at the University of North Dakota, a certified nurse midwife, and a certified lactation counselor. She practices in women's health, obstetrics, and family planning in a variety of settings, and has been involved in SAMHSA-funded grant work since 2014, spending 3 years on an interprofessional SBIRT training grant, and currently is working with Region 8, which is Mountain Plains Addiction Technology Transfer Center, and the Mountain Plains Mental Health Technology Transfer Center Network. Dr. Shogren is also the principal investigator on the Foundation for Opioid Response Efforts grant-funded program, Don't Quit the Quit. So welcome, Maridee. We're really happy that you could join us today.
Thank you so much. It is an honor to be with you all today.
Okay, great. Well, we'll go ahead and roll the video, and then let's have some discussion, and we will be inviting audience comment at that time.
Welcome to our video series on 5 big ideas in overdose prevention. The following clips are from the National Overdose Prevention Leadership Summit and focus on Big Idea number 5, reach people where they're at.
First, we have to integrate addiction treatment, prevention, and recovery into mainstream healthcare, so more people have access to quality care and early interventions. Second, in April of 2020, during COVID, the federal government provided flexibility for telehealth and take-home methadone. Now, the intent of this flexibility was to ensure continued treatment at a time when social distancing was necessary. And that flexibility appeared to have positive results. For example, a survey from North Carolina found there was little diversion of take-home methadone, and other reports found that people stayed in treatment longer because of these additional flexibilities. Now, a study from George Washington University has found that the federal government has the ability to continue these flexibilities. So the federal government should act soon to extend them and remove barriers to treatment. Syringe services programs, as I've mentioned, serve a population at great risk for overdose and bloodborne disease like Hep C and HIV. Now, these programs provide life-saving services, and they also require ongoing funding and the support of local communities. Workers at syringe services programs build trust and engage with people who use drugs by providing them with testing, referrals to treatment, and other services that reduce the risk for overdose and bloodborne diseases. And these services are provided without stigma. They also save taxpayers money. For example, the Indiana State Department of Health credited syringe services programs with saving taxpayers about $120 million by reducing bloodborne diseases that are associated with injection drug use. An additional policy area of focus is to get treatment to people who are incarcerated. Now, one of the groups most at risk for overdose are people who are re-entering society after leaving a jail or a prison. The reentry population is up to 40 times more likely to die of an opioid overdose within a year of release from incarceration than the general American public. Now, this is mainly due to diminished opioid tolerance while someone's incarcerated. Now, some states are providing evidence-based treatment for incarcerated people, but that's still more the exception than the rule. Yet the evidence shows that providing medication for opioid use disorder to incarcerated populations reduces overdoses. In fact, people treated with medications for opioid use disorder while they're incarcerated were 75% less likely to die of any cause and 85% less likely to die from an overdose after release from a jail or prison. The Federal Bureau of Prisons can lead the way for other state and local jurisdictions that are exploring jail-based programs to treat opioid use disorder.
But in that development of that provider network, we also have really close collaboration and communication from the PHMC and around developing new services, new supports to meet the needs of the participants. Our case managers are out in treatment programs, they're out in recovery houses, they're actually out in the individuals' homes. So we're seeing on the ground what is really happening with individuals and can identify where there are gaps in services and make recommendations back to the larger systems around ways to help support this population of individuals we're serving, and in particular, the specified needs of women and children. For example, in the last couple of years, we have really advocated for an increase in the number of recovery houses for both women and women with children. There was one recovery house which PHMC ran many years ago. It was actually a recovery house I established back in the mid 1990s that faded away for numerous reasons, and there was a gap in services for that. But it was the one thing that we continue to advocate for, because women would be leaving treatment programs where they were allowed to bring their children to treatment, but then when they had to step down to recovery house as sort of their transitional housing, there was nowhere for them to go. Well, I'm happy to say, because of that advocacy work in the last year, the city has identified at least 2 houses that will take women and children into their program post-treatment as a transition from standardized treatment for women and children. So that's a big win for us, but that's also the role that we play. We continue to advocate on behalf of our participants.
So one of the things that happened that I think will be very helpful moving forward for natural disasters, but was spurred from the pandemic, was the fact that the DEA rolled back provisions on something called the Ryan Haight Online Pharmacy Consumer Protection Act. And this is basically a law that previously prevented prescribers from being able to provide buprenorphine and other controlled substances without certain criteria being met. And it was obviously created as a way to protect patients, but it had served as a hindrance to being able to get people started on medications that they needed. Buprenorphine, which is a life-saving drug, and I completely agree, it needs to be talked about just like we talk about other life-saving medications. It is a Schedule III drug, and so previously it could not be prescribed without having an in-person, face-to-face visit. Now we are allowed to prescribe with a telemedicine visit without an in-person exam. There's also been some changes in the way that we can prescribe Librium and Ativan, which are medications that are benzodiazepines, very important for helping people to safely detox from alcohol or benzodiazepines when they're left in a situation where they previously maybe had access to alcohol or their Xanax and now they do not. And so we can at least make sure that they're not going to have, life-threatening seizures or other implications from that process. It's unclear whether this is going to be a permanent change at this point, but it would be really hard to go back at this point. So some of the barriers that people face when there's a disruption to services or when there's some sort of a disaster. So disruption of services like the infrastructure. So maybe programs are closing down, they're not able to open, maybe their bed capacity has gone down, and so they're only able to intake 50% capacity. Furthermore, there can be displacement from their homes. So their location is constantly changing. Mary talked a lot about shelters. People can be in shelters, temporary housing, and they can be moved around quite a bit, maybe staying with a friend in another county or another location. They might have the inability to physically come in because of transportation issues or a geographical change that's now made their bus route or something change. And then finally, just not having stable phone access. Some of the solutions that we adopted and had actually been trying to build before, because the nature of the patient population we serve was to, first of all, have multiple access and locations and multiple modalities. So this isn't always possible if it's a small organization. We have 22 clinics that expand all the way from the border up to North County and then into our rural areas. And so that was really crucial, and I think will be crucial for us going forward, in that if we have a fire in Campo in a rural area, we have other centers that we can try to provide people services, although I totally recognize that that's not always possible. Having vans or a mobile units is also a really great way to address that. Again, this is with or without a natural disaster. We're trying to reach a population that is constantly on the move. And so a van is a great way to be able to meet people in different locations. Then again, I mentioned being able to try to maintain face-to-face where possible, but also really expand those telehealth services. And that's been really just opened the doors to reaching a broader patient population for us. Direct phone contact. So I feel so strongly about this. What I mean is that if you've ever given someone an 800 number or some sort of number, do not give it to them unless you've called it yourself, because I cannot tell you how frustrating it is to be in crisis and to be given a number and call it and to be sent on a wild goose chase. And so I feel like I talk about this all the time in my organization, and I'm not sure people really understand why I'm so passionate about it. But I think for me personally, I've been on the other end of that as a youth seeking services, and just had 20 numbers, and every one I wasn't eligible for, maybe because I didn't have a baby, or maybe because I didn't have enough felons, or whatever the reason was, or felonies, whatever the reason, I wasn't eligible. And so I really believe in providing phone numbers that we've tried ourselves and that are direct contact lines, where someone picks up the phone and is able to address the person in a compassionate manner and say, you've called the right place, we're gonna get your needs met, and then get them to where they need to go.
So when we decided to think outside of the box at Don't Quit the Quit, we really looked at this ability to collaborate with our local WIC agencies. So we thought, could we collaborate with them? Could we talk about healthcare conversations surrounding substance use disorders with women in the perinatal period, and how comfortable are they talking about this? And it's been really enlightening and such a privilege to share the work that WIC agencies do. They are integral to substance use disorder treatment and recovery, especially in our rural communities. They provide ongoing support during this perinatal period, and they really have the ability to fill this gap in perinatal care. Many of you might not be aware that only about 40% of women in the postpartum period ever return for even one postpartum visit to their obstetric provider. Sometimes it's because of the rural nature of where they live and a difficulty getting to those appointments. Sometimes they just don't feel comfortable. Sometimes they may have started with a treatment provider for their substance use disorder, seeing a different provider for their obstetric care. And now, okay, I had my baby. What do I do? Where do I go? And what we've found is that many women feel very comfortable returning and staying engaged with WIC. They've established that rapport prenatally. It's a good, comfortable place for them to go. So WIC support for mothers in recovery actually influences their ability to return to use. It provides them with critical nutritional support to help them sustain their recovery and their breastfeeding efforts while they're in treatment. And it's a place that provides acceptance and non-biased care that helps us continue to break down the stigma that they're experiencing.
So what I've heard from working with programs across the country and in California was how to set up a greater network of care that taps people outside of our immediate region when a disaster is constrained by a region. How do we make sure that, you know, a program in a neighboring county can show up when they're less immensely traumatized and impacted by that disaster? So kind of setting up, you know, things. Mary spoke to the fact that you might have a really good system of care in your county or within your network, but a disaster happens and those people are spread out around, right? So how do we kind of create different broader rings of care? And I think the other thing I would add, knowing how deeply both service providers and participants have been experiencing ongoing trauma related to this and systems disruption, is that programs have been incredibly resilient and incredibly adaptable and have come up with strategies to already have plans for these things, right? We see that from 2017 to 2020 in the California fires, huge growth in our systems for people to respond, to get people what they need. And so how do we kind of at all levels and all the populations we're thinking about continue to look back to community, to what they have discovered and implement that in a systems level way. Always considering those people who are the most marginalized and who were often wrote off. And I think Mary made some good suggestions about sort of how we can place these things as being the best for all people involved and not allowing us to write certain people off.
But there are many things the federal government can't do. Only local communities can build a response that truly reflects its unique needs. And our addiction response too often requires people to meet us where we are, rather than meeting people where they are. So building responsive communities, reducing stigma, developing a sustained approach that doesn't treat the issue like it's episodic, that's going to go away in a few years. All of these steps are required to bring down rates of overdose and reduce the harms associated with substance use disorder.
I think there are lots of really, really excellent kernels of ideas for us to be discussing. I want to just remind everybody to put their comments and their questions into the Q&A. And Erin, I see you made a note that in Arkansas, you still might require a face-to-face visit. So we would all hear that that's a really big problem. And I think that what you have to do is start reaching out to your state health department and see how you can organize some pressure for them to respond to the fact that the federal guidelines are now permitting distribution, and if the feds are allowing it, what's holding it up in the state? And that's not, that's probably not the easiest, but I have a feeling that you're probably really good at advocating for, for the right thing that needs to happen, bringing it up in the priority list. So Maridee, I just want to get started with asking you a few questions now that you've seen the video and seen yourself, but also some of the other really great speakers that we had there. What have you found in reaching people in places with limited access to resources? I know you have had tremendous experience in working within rural communities. So what do you think some of these strategies are for really getting out there and reaching folks? And I love how you talked about what you might want to actually start with that.
With the progress we've made with WIC. Sure,
Yeah.
Certainly. So I think, first of all, I want to say that any of us who come from a rural community, we kind of immediately have this type of a common bond. We kind of get it. We kind of understand the difficulties of reaching people where they're at in those communities. I love the poll questions, Carmen, because I knew immediately that 26% of the people came from Midwest areas and 40% lived in rural areas. And I went, they're my people. They're going to get what I'm saying. So it's a place to be relatable, and we can talk about interventions that make sense in those areas. One of the strategies that we utilized was working with their WIC agencies, because we knew that this was a safe place. It was a common place where all pregnant and postpartum, most pregnant and postpartum moms in that community would go to access nutritional services. But we also knew that there was a hidden population there of pregnant and parenting people who maybe weren't comfortable disclosing substance use disorders at their home clinic. If they were lucky enough to have a treatment provider in that community, they may have that discussion there. But as they develop a rapport, as they go back and continue to see WIC, they have a place of care where they can be comfortable talking about things in a less threatening situation. And so we learned real quickly that WIC embraced this idea, that they had people working in that agency that said, yes, we have to ask questions. We have to ask screening questions about substance use disorders. Sometimes we're not so comfortable asking those questions. And so the strategy became to help them with some foundational information about substance use disorders, and in particular opioid use disorders. We talked about why we ask the questions that we ask. Makes good sense. So they became more comfortable asking those questions. And then we talked a lot about the idea that sometimes their role is really to provide that education and possibly facilitate a referral. So taking that pressure off, that we don't have an expectation that you're going to treat people, you're going to go into in-depth discussions, but really work on that screening. And your area of expertise becomes, how do we refer and make people aware of the services that are available to them?
Yeah. Good points. So one of the things that I heard echoed in a couple of places during the video we were just watching is how the kind of resource that community people bring to the question. So it's not just government and institutional resources and answers, but also when communities are mobilized and start asking the right questions and getting engaged and getting involved, how do they also help to push upwards and change the systems and change the practices? So I wonder if you maybe could talk a little bit about how you've incorporated local community members in your efforts in order to reach people where they're at.
Sure. So of course, WIC being one of those community organizations, but we also took a broader look at that community, and we thought, where are the other resources, the other organizations that pregnant and parenting people would reach out to, and where are the gaps? Where are we missing some things? So for example, we worked very closely with 2 tribal communities. And in one of those tribal communities, they had a very well-established home visiting program. So they had home visitors that would go out to visit families. They identified to us that they felt they had a large population that was impacted by substance use disorders. And we did the same thing. Could you benefit from some more foundational information so that they could share that information in a home where people already felt comfortable? So they could just continue to provide that network. They also could incorporate screening if they wanted to, but they would more importantly know about where to find education and where to find resources. If we looked at the gap side of things, we really focused on that postpartum period, starting with the basic education that the postpartum period lasts a full year. So, people aren't done with their baby experience after 6 to 8 weeks, but what do we look like in this year after having a baby, and how does that impact a family? And so we also trained community members who understood their home communities to become postpartum doulas. Now we have somebody who's already identified in that community as a person who's lived there, is invested in that community, and then they bring to the table some extra expertise regarding postpartum care. So this becomes the person that maybe is that first point of contact. I have these questions. I know you're comfortable working with people who are postpartum. I know as part of this program, you're also open to talking with families who are impacted by substance use disorders. Can we have a conversation? And again, the referral continues.
Well, it's a really good way to build more, both build more connection, but really build more value
Yes.
at the community level, and then that trust, which is so important because somebody from the community is
Right.
speaking at the community level. So
Exactly.
that's a really smart strategy. So one question that's come up from the audience that I wonder, maybe since you've worked in a lot of rural areas, you have some experience with, is the issue of not getting data in any kind of real-time way. Were there any tools or any particular ways that you found for getting information about where your hard to reach populations are that you want to share? Any ideas about how to get that data? I mean, this is always a conundrum. How do you
Sure.
find out where people are?
It is. And I would say I'm open to those suggestions as well. So when we actually wrote the grant, we struggled. How do we find this information? And so we had to kind of look at many different avenues, and we also had to include anecdotal information. And what does that look like? So we realized that within the state of North Dakota, we didn't do a great job of tracking pregnant and parenting people with opioid use disorder by diagnoses. So we couldn't get that. But we were able to track how many people disclosed opioid use disorder and sought treatment at one particular state facility in North Dakota. And we were able to determine where a large subpopulation of those people lived. And so that's where we built our 8-county region to start. We knew that 36% of pregnant and parenting people who sought treatment lived in this particular region. So that's where we started. So we didn't have a set number. We didn't know exactly county by county, but we knew a region, and that's where we started. Now, after that, we also found that because there were so few providers who were providing buprenorphine care, medication-assisted treatment, we didn't have good solid numbers of how many people were engaging in that care either. And that's still a pretty loose figure that's out there, but we knew how to identify the pockets and where we felt that we could at least geographically help provide more services to target or to assist people in that region.
That really good thought. Here's another comment from the audience that I want to maybe have you incorporate a little bit into your thinking. Syringe exchange programs are the perfect place to connect with individuals and are sometimes already a hub for connecting to other resources anyway. And is that something your program has done?
Okay, I would agree with that thinking. However, our program was focused in very rural areas, and the stigma is still so significant. I cannot think of one syringe exchange program that it now exists in the original 8-county region. Halfway through our grant period, we did extend to 12 counties. And now that we did that, there's one syringe exchange program that would be available. But where that sits would be in the more urban setting that we included, but in the very rural areas, I would bet that discussion would not move past a city council meeting. The stigma is still so significant.
Yeah, and that's true for so many of the communities that we are working with, and so trying to build more knowledge around syringe exchange programs, and I think that there actually is quite a large federal push right now to try to lift up the importance and the efficacy of syringe exchange programs. So maybe in the next couple of years that could change, but I really want to thank Alicia for bringing that up, because there's no question that it can be a good service as a hub.
Sure. And if I could add to that, the other thing that we sometimes forget when we talk about syringe exchange programs is really communicating to communities and rural populations, for example, that it is a type of harm reduction. And we've talked about this in many, many ways. And how do we bring that idea forward without it being too scary? And sometimes starting with a syringe exchange program feels too scary. But we talk about in farming communities, the use of fertilizers and weed prevention so that we can grow a healthier crop. Okay, that's harm reduction. We talk about wearing seatbelts. We talk about preventive care when you enter a healthcare primary care office. What does that look? That is harm reduction. So sometimes we've been working on changing our dialogue and how we introduce those kinds of things into communities.
Yeah, really good points. So one of the things that is brought up here in the Q&A, and since you've worked so much in rural communities, what do you do with people who don't have stable access to internet, or don't have transport to do telehealth at a clinic? What other strategies are out there that you're aware of?
Right. So one thing that I should probably point out is that when our grant was funded, it was in February of 2020, and we all got sent home in March of 2020. So we really had created this program based on the idea that in-person, face-to-face was going to be the ticket in rural areas. I grew up rural. I know what it means to go to the local cafe and introduce yourself and find out who knows who and how you start building that network. So very quickly, we had to shift gears on how is that going to work. And the first thing we did was shift to virtual, which wasn't always accessible. However, when we talked about these virtual webinars being recorded and being accessible, we learned that many county libraries or city libraries would offer internet access. They could go there to look at that. We also learned that sometimes recruiting or putting out information in our program, the most requested methodology for that was actually the old-fashioned flyer. Could we hang up a flyer in a community? Could we have that actually then engulfed into a trifold brochure? People really like that because they could stick it in a purse. They could put it in a folder or something else, and it felt more private, and they could have that information. So we went back old school. We also did a lot. I loved one of the people on the video talked about the importance of the phone. We called and called and called, and that is what we did. Is we looked at the local organizations. We called. We introduced ourselves. We talked about the program. We used the phone to do that. Just to make things more accessible. And then we found that we were printing out information to distribute because that worked better in some communities.
Yeah. Well, before we go over to the questions and get the audience engaged in thinking and giving us their ideas via the Q&A and our conversation on that as well, talk a little bit about Don't Quit the Quit. And what were some of the communication strategies that you utilized in order to better reach hard to reach populations?
Sure. So a lot of people ask us what Don't Quit the Quit means. And I think it's a really good place to start. And our intent with that was that we didn't want pregnant and parenting people to quit their recovery. We wanted to be able to find ways to help them sustain that recovery and feel supported in that recovery. So communication strategies really began with addressing stigma first in all different ways, whether it was an educational webinar that we offered, we made that free, we recorded it, people could access it at any time. Talking with people just to share that as part of our provider training. We learned that often in rural areas, providers feel a different kind of stigma for prescribing buprenorphine, for example. So we had to tackle that kind of stigma and use that as a communication strategy. Let's talk about that and how can we change that? We use the old school things that we talked about. Word of mouth was huge. I can't stress enough the importance of talking to and with people in recovery. So one of our most successful webinars featured a local mother who has been in long-term recovery, and she shared her journey. And we felt it was very important for people to hear that because we knew that it wasn't always clients with opioid use disorder that would log into our webinars, but possibly family, possibly friends. They were just looking for education and what would that be like. Sometimes it was the clinic staff that we were working with. Sometimes it was WIC providers. So to actually hear somebody in recovery talk about their story became a very, very effective strategy for others to say, I could maybe envision myself now seeking treatment. Oh, I didn't know that was an option. Oh, I didn't know that provider was here and could help me in this capacity. So I think working with people in recovery is huge when we start talking about the strategies necessary to increase the accessibility to care.
Yeah, that's always an important thing to underscore. Thank you for that. So let's get the next slide up. We're gonna pivot the program a little bit so that we are more incorporating the thoughts and the experiences and the questions from the audience. So we're going to put up some questions and we'll be looking through your responses to see how we can, we can further amplify these ideas and really help each other to think further about what kinds of challenges we face, what kinds of opportunities are out there, how do we create more value in our communities with respect to reaching the hard to reach communities in our populations. So to all of you, What is one hard to reach group or population in your community? And you can think about that as we look at the next question, which is, next slide, please. List one strategy your organization might utilize to reach marginalized populations in your community. And then let's look at the final slide. How have you worked to make overdose prevention resources and services more accessible in your community? So with those questions in mind, we'd like to hear from folks. Please, go ahead and use the Q&A, and Maridee and I will be talking about what you're adding to this conversation. With as many people as we have on this meeting, it's pretty hard to hear from your voices. So that's why we're using the Q&A. And I know that so many of you are really, really good at doing this. So one set of marginalized communities that's stated up here is Hispanic and African-American populations. I don't know, Madison, where you're from. And I do think that that is perhaps very true in so many communities across the country. Poor communities being very hard to reach, people of color in general. North Carolina, well, yes, and there are many other places where we could say the entire state is a hard to reach community. Some hard to reach communities sometimes is the faith-based communities, and pregnant teens are out there as being a hard to reach community. Wondering, maybe Maridee, since you have so much experience in that area, if you want to just comment on
Sure.
reaching pregnant teens.
I wouldn't have a lot of strategy with pregnant teens per se, but what I would say is that particular population is often also stigmatized, especially in rural communities. So making sure that they had access to both obstetric services as well as substance use treatment services may become more difficult in rural areas because we don't often have the expertise needed to treat a teen population. But knowing and understanding that they can be treated within a primary care system and it's there, it just probably requires a little bit more education and again, reduction of stigma to do that. Mm-hmm. If I could, Carmen, one thing I would like to add when we start thinking about more marginalized populations is that I think sometimes we also have to go outside of the box a little bit. And I would argue that sometimes a very difficult population to reach in our rural community, just from the experience we had, would be obstetric providers, simply because we don't have them. And so in a rural community, we run into, if we do have somebody with obstetrics experience, they often don't have substance use treatment experience. If they treat substance use disorders, they might not have obstetric experience. So thinking outside of the box to look at very well-respected providers that provide care in our rural communities, sometimes they are a hard to reach population because we're adding another skill set or we're asking them to do more or look at things a little bit differently. So really thinking about that whole inclusive picture of really you could identify many ways any population could be looked at hard to reach, but thinking about how to increase that accessibility.
Yeah, thank you. One of the, somebody here has said tribal and Latinx community members can be hard to reach, but also I think underscored elsewhere in the string of thinking here is, there really are very different tribal communities. So there are urban Indian communities and they are reached maybe in one way. Maybe there's a community center or a community clinic that has built a foundation that can be built upon. But another point made here is that perhaps in very isolated areas, Indigenous communities pose a whole different set of issues that need to be addressed in order to reach them. I'm just thinking in California, we have a number of folks up in Northern California where it's extremely rural and, where it can be really, really challenging to get folks who need services, the services that they need. I think one lesson that we learned from them in working with the Yurok tribe, which is very, very rural area. They're located in a gorgeous but very, very rural and very poor area. They were some of the first folks to pivot to using telehealth. At the beginning of the pandemic, sure. they were on it right away, and it was sort of necessity is the mother of invention. and they taught us a lot of lessons about how to be more effective in getting people what they needed when people were so isolated at the beginning. We didn't know really what was going on. People living in encampments being pointed out as being a very hard to reach population. And I think we could all underscore that's very, very true. And just want to make sure that I can find if anybody else has listed up a community we haven't thought of or touched on yet.
One other thing that I could add while you're looking, Carmen, with the tribal communities is that we learned very quickly that we worked with 2 different tribal communities. One was a little bit more open to us calling and talking about the program. Another, we worked very hard to find nurses in that community. Gratefully, I had taught them as students, and so made that reconnection back. But because they lived in that community, they were able to introduce our program from within. And as a result, we were able to have 3 Indigenous women who went through our postpartum doula training so that they could bring that expertise back to their communities, because they view birth in such a beautiful way. Pregnancy and parenting are looked at in a different cultural sense that I didn't have an understanding of because I wasn't part of that community. So really looking for those community experts who live and work in those communities and are invested in those communities makes a really big difference in how we create that accessibility to care.
Yeah. So I think one community we haven't really mentioned yet, and I want to make sure that we don't forget them, are incarcerated people.
Yes.
And and thinking a little bit about what some of the strategies are that each of these communities might find that we might find to be very, very helpful in trying to more effectively connect with folks that need services. So one person's comments is trying to reach people who are unhoused via the places where they are already accessing non-drug related services. And I think that's, we're thinking about substance use, so we're thinking about drug treatment services, but we're not thinking about maybe all of the other places which could be potential points of contact. Sure. That could reach people who are unhoused and who are more dispersed and less connected to the usual structures that we might set up our access points around. And then let's see what other strategies we have here that people have listed. I know I saw a good one. Placing Narcan on the counter in local businesses, especially dollar stores, immediate care offices, tobacco shops, etc. A training card and support resource strategy or resource card is also included. I think that is really an interesting strategy for reaching people that you otherwise don't bump into or don't knowingly bump into, who might really benefit from a connection. That's a very interesting way of connecting. Thank you, Julie, for that. Let's see here. Target outreach to specific marginalized populations. Teens and youth in transition from foster care who have SUD are hard to reach. Strategy: connect with direct service agencies these youth connect with and partner with them to educate as needed regarding substance use disorder treatment and prevention and treatment, and equip them and empower them to share out with youth they serve. So reaching the other agencies that touch upon that population. Another person is offering that mobile units that can bring harm reduction services, harm reduction resources and medical providers directly to homeless encampment to serve folks that are unhoused. Somebody who's commenting on a hard to reach population, and they're highlighting the Somali community in the place where they live and work, that they've been actively looking for bicultural, bilingual persons, because having experience with SUD is very important since there's such huge stigma in that community. So that's, setting up a number or having to deal with manage a number of barriers at the same time. Being bilingual, being bicultural, managing stigma, and finding and connecting in a genuine way with a community that can get marginalized very easily with respect to these types of services. Here's somebody working in an ER where they have just rolled out free Narcan distribution programs, working on obtaining free fentanyl test strips now. The Narcan is available for everyone in the community, not just patients. Very good. I've also just helped increase the number of ER providers who are X-waivered, and we increased the percentage from 44% to 83% in 2 months. Wow, that's an incredible accomplishment in just 2 months. So hats off to you. And then here is a comment: families currently involved with child protection cases being a hard to reach population. When visiting a family in labor and delivery unit recently, they'd been told their kiddo would be removed from their care, and the mom reported feeling, it's like, I'm the world's biggest piece of shit. I think she was hearing and feeling that from every single person. The family had to have a constant supervision in the room with the newborn, and the father was holding the child silently and said, I'm not good at asking for help. Mm-hmm. The unit usually gives books to every family, but the books were on order and not available, and the family had no support system to bring them any baby items while they were in the hospital. When I asked about giving them a book to read to their child so they could have a bonding activity, maybe borrowing from PEDS unit or something, I was asked why they would need to bond with their baby if their baby wasn't going home with them. Ugh.
So Carmen, can
yes,
I weigh in and share something here? It's absolutely heartbreaking. And so another thing that I would like to share is that we worked very closely in some of the SAMHSA grant work that we've done with our Addiction Technology Transfer Center in a very interprofessional fashion, meaning that one of the first populations that we worked with on that grant were our social workers. We have a Children and Family Services Training Center in our state. They train all of the social workers in the state, but they also work with foster families, and they were strong advocates to look at alternative response in our state. How can we keep moms and babies together? When we started the first year of our Addiction Technology Transfer Center grant, we trained over 160 social workers in our state simply to give them foundational knowledge about substance use disorders. Many didn't. They readily said, I don't quite understand it. Can we talk about it? What is the impact on the mom? What is the impact on baby? What does this dyad look at? We also included foundational information on pregnancy and postpartum because it tied so closely into this population, and they had a lot of questions that they didn't know who to ask. And so by providing that foundational knowledge for them and working with them on that understanding, again, the screening becomes different. The desire to care for families looks a little bit different. How do we keep families together when it's possible? Looks a little bit different. So it is important for us to think beyond each of our professions and how do we work together to do that?
Yeah, good point. Good point. So here's a comment that in New Mexico, they have a large variety of cultures, Latinx, Native American tribes with unique languages in each tribe, and learning to become respectful of the specific customs, specific practices, who are the influential people, how do you reach them, all of those things. New Mexico is such an interesting place in that regard. So thank you for that comment. And then another comment here about reaching people experiencing homelessness, using a food pantry in addition to harm reduction supplies and the ability to do rapid testing, and also having a phlebotomist. So I think, Alicia, that's a very interesting set of things to bundle into a food pantry, and would certainly advocate for thinking about that as a value opportunity, place to build additional value for the community that needs those services. Here is the Women's Connect Shasta.com website that offers a comprehensive list of resources for women of childbearing age to access support and resources, using motivational interviewing language throughout the website to engage women, putting out posters and cards all over the county for outreach, and collaborating with the local SUD treatment centers to ask women what they need and want in terms of help. So very, very, very creative. Sounds like a lot of hard work, but I think probably very well placed hard work. My clinic and sister clinics are starting to get permission to dose our incarcerated patients. Excellent, Madison. Think about syringe exchanges, please. I am, another comment from Jessica, I'm the mobile opioid support team coordinator. I meet people where they're at, in their home, treatment center, jail, prison, park, etc. I will bring fentanyl testing strips and naloxone to whoever wants them. We're a rural community and are opening an SSP in a couple of weeks. So congratulations on that. That sounds like great strategy. We have a syringe exchange program and a new community with big accent on the U van for testing and treatment of STDs and vaccination access. Excellent. Naloxone at hotels. Boy, that's brilliant. Responding that I work in a place that you can come to here for crisis assistance. The amount of hours for walk-in services from 10 to 10 on weekdays, 10 to 6 on weekends, see young children on up, and can at least provide resources for humans and connections to human services. In Seattle area, success with syringe service programs, partnering with harm reduction doulas who do outreach to parenting and pregnant people who use substances. Narcan at motels as well, in front desk, vending machines, etc. These are some very interesting strategies. Any thoughts, Maridee?
I love them all and we need them all. Yes, it's that outside of the box. We have to
real outside of the box.
Community for sure.
Yeah, well, here's another good one. Bike shops, heavily utilized by folks experiencing homelessness in our town. We're working on getting training to all the local bike shops from our public health team to provide education, harm reduction, and reduce stigma. I love that.
Wonderful.
Partnering with a variety of community-based organizations, Department of Social Services, law enforcement, and outpatient treatment centers to create satellite OOP sites and referral centers. Very good. Going into homeless encampments, go to where those people are and bring Narcan and fentanyl test strips. A local community health center has the Hope van that provides medical care and assessments to homeless. They have a doctor that provides homeless care by going out to the homeless camps and providing medical care, brings the supplies in a backpack. People with co-occurring challenges are the ones that are the hardest to reach. That is the truth. You speak the truth. Using recovery members in social media to identify Narcan holders and a free Narcan link. First Clinic in Washington is a great model for supporting families as well as at risk for child welfare involvement. Just reaching out to other organizations in general. These are really, really wonderful suggestions. And I'm thinking part of what we're going to do is pull them together in some kind of a document and attach them when we post this session, which will include all of the discussion and the video and the questions. And I'm sure that we can get up all of these comments from people. I want you all to be sure to check out the resource library at www.nopn, that's NOPN.org/library, and select hard to reach tag for more resources on this topic. We have videos and resources on how to reach people who use drugs, on Indigenous communities, those who are incarcerated, and more. We also have videos on key approaches to reach the hard to reach, including harm reduction strategies, telemedicine, and preparedness for climate-related disasters. So that's just a prompt to me to make sure that I mention to all of you that we will be moving in this series to another, to the next session, which will be willing to pivot. Today we did reaching people where they're at. The next one we'll be doing on Wednesday, June 22nd, will be willing to pivot. So please, I want to ask all of you, join us in the last two webinars of our series. And we should be willing to pivot in our strategies, but also why we don't need to reinvent the wheel every time it comes to evidence-based overdose prevention strategies. There's so much knowledge, there's so much wisdom and so much experience out there. We need to connect with each other and make sure that we are sharing the best knowledge and the best, some of the best experiences. So back to the last slide. Everyone, please let us know what we can do to support your efforts. Contact us at nopn.org/contact. And there are so many more resources on the website that you see posted there, nopn.org. And we hope that we will get to see you next time. Thank you so much for joining us.